So acute decompensated heart failure. So heart failure in general is decreased ability of the heart to effectively pump blood. So the heart perfuses the whole body, the brain, everything to make the body function, and now for whatever reason it's failing, that tends to not be good. So a couple of causes. First off, myocardial infarction, so a heart attack. So what you do is actually kill off heart tissue. It obviously can't pump anymore. Valvular disease, so anyone has problems with the valve either from birth or from some other problem down the line. Congenital heart disease, all these reasons can cause heart failure. Also high blood pressure and pulmonary hypertension. So either the pump is broken, the heart's broken because of something like a heart attack, or you're making the pump work harder because it's pumping against high blood pressure or pulmonary hypertension. Those can make it wear out. So a couple terms we'll talk about. First off, ejection fraction. So that's the percentage of blood pumped out from the left ventricle. So you have diastole here, and then your blood pumps into systole. So that percentage that comes out of the heart is what's called the ejection fraction. And normal is about 50 to 60%. So every time your heart pumps, you're pumping about 60% of the blood that's in there out. So as that starts getting down 20, 30, 10, that's bad. That's heart failure. And obviously you're not pushing out as much blood as you need to. So when we talk about ejection fraction, there's two different types of heart failure. First off is systolic heart failure. So systole is when your heart pumps. So the systolic portion of that pump is failing. And this is mainly, like we see here, weakened heart. So you get a myocardial infarction, a heart attack, it weakens that muscle, it can't pump as hard. So that's one type of a heart failure. Another type is called diastolic heart failure. We don't hear about that as much. So in this, you actually have a normal or near normal ejection fraction. So you're still getting 60% of that blood out, but the amount of blood coming into it is decreased because you have very hypertrophied, thick muscles, usually due to long-standing hypertension. So again, you're pumping the same proportion out, but the amount that's able to come in is actually less. So that's diastolic heart failure. So you can also divide heart failure in two different sides. And this isn't that important for you to memorize, but in case someone says I have left side or right side of failure, or you hear us talking about it, the type of failure causes different symptoms. So left side failure is most common. So your left ventricle, again, maybe from a heart attack or something, it's weak, it's not able to squeeze as well. The right side of your heart is also something that you can have, but the most common cause of it is left-sided failure. So your left side fails, it backs blood up, your right side has to pump harder against that blood, it now fails. So again, most common cause of left heart failure is actually right heart failure. And now we'll talk about some basic physiology of the heart and how blood goes through. Most of you guys are familiar with this, but just so, again, we understand how the blood is pumped. First, it goes from the body into the right atrium. This is deoxygenated blood. It then goes right atrium, right ventricle, out the pulmonary artery to the lungs. In the lungs, it gets oxygenated. Comes back to the heart through the left atrium, through the left ventricle, out the aorta to the rest of the body. And so this is a closed loop. It's a closed loop system. So what goes in must come out. It should be equal. And also what gets blocked on this side, it gets backed up. So that's how we start talking about things about afterload and start talking about right heart failure. The reason that happens is because if you have more pressure on one side, your heart is now pumping harder against that and it's going to fail. And we get different symptoms based on the side. So these are kind of your classic symptoms of heart failure. If your right side is affected, again, the right side coming from the right atrium backs up to the rest of the body. So that's when you get your peripheral edema down here in the legs and you get your JVD up in the neck. If it's pure left side failure, you might not see those things. If it's just your left side, you may not actually see those problems. You're only going to see problems in the lungs because the left side backs up through the pulmonary veins into the lungs. And so that's when you get your pulmonary edema and get your crackles on exam. So again, the exam findings you find are based on the type of heart failure. Not all heart failure is not the same. And two more terms I'll talk about, preload and afterload. And the reason it's kind of good to understand these is that when we start talking about medications and what they do, you can see why some medications work and some don't. Preload is the volume of blood that's in the ventricles after diastole. So the ventricle relaxes, it has a certain volume of blood, that's what's called the preload. That's different from the afterload. That's the amount of pressure the heart must push against. So one's the blood that's coming into the heart. The next is what the heart is pushing against. And that comes into effect, again, when we talk about medications and what effects they have on the body. All right, so you guys get on scene. We're going to talk about how to treat these patients. There's a couple different mnemonics out there. One is LMNOP, others are unload fast, others are unload me. A lot of these mnemonics are kind of outdated. and they have some components that we don't really want to use as much. But we'll go through the LMNOP because I want to go through each phase of it, because this is kind of the classic one, and say why each component is good and why each component is bad, and we'll come up with a final mnemonic in the end. So LMNOP, what this stood for was Lasix, morphine, nitro, oxygen, position, and positive pressure ventilations. We'll go through each component now, and we'll kind of look at the literature of each one and try to figure out what's the best thing to do with each one. So Lasix, or furosemide, this is a loop diuretic. The way it works is it blocks renal absorption of salt and water. So you got your kidney here, you got perfusion into the kidney. With that comes salt, which is the white particles, and water is the blue stuff. And then what your kidney does, it keeps some of that and it pushes some of that out, and it pushes urine out in the end here. When you give someone Lasix, it blocks the reabsorption of salt. So it causes more salt to go out in the urine, and water follows salt. So you start excreting more water. So that's why a lot of people call it their water pill, because it makes them pee more. And the way it does that is it forces more salt out of the body. So that's the good thing with furosemide. It's good. You have too much water in the body, too much fluid, now it's helping you get some of that off. The bad side of it, onset's a little longer than we like. I would compare it to like nitro. Nitro is much quicker. And onset 5 minutes is for IV Lasix. If you do PO Lasix, it's a couple hours before it actually has onset. And it lasts 2 hours. To me, that's kind of long for the pre-hospital phase. I don't really love anything the pre-hospital phase is lasting that long, because especially these patients, they can take a lot of different courses in their condition. And you may be giving something that's going to last longer than you want, because I'll tell you in a second why that exactly is. The other reason is this patient comes in short of breath, edema. Yeah, it can be congestive heart failure. Lasix is great for that. It can also be pneumonia, which Lasix can kill people with pneumonia and sepsis. It can be a heart attack. Lasix can kill people with heart attack. It can be right heart failure. And if you have pure right heart failure, or say in a right side MI, we're preload dependent. We need that blood flow coming back. So if you start dropping their preload, dropping their total systemic fluid, you can actually cause some bad things in these patients. So 2 studies here. This one was in 2015, looked at 330 patients. A third of them ended up having a diagnosis different from CHF. So when they actually got discharged, it wasn't actually CHF, it was something else going on. In this study here, 42% of patients had a diagnosis different from CHF. So again, you guys are getting called a CHF patient, but it ends up being something different. There's very little way that you guys can differentiate that in the field. This is what you have in the field. You have your hands and the stethoscope. That's about it. We have many more things. We have our X-ray machine. I can see if they actually have good pulmonary edema. Ultrasound. This has changed the way we treat CHF patients. I can tell you right then and there if that patient's actually fluid overloaded. And then we have time. Time is the biggest thing on our side. When you're in the back of the truck for 10-20 minutes, you cannot be expected to actually diagnose CHF. It's very hard. These patients might get to me sometimes, and I do an ultrasound study, look at their fluid status, and they're actually fluid down, and they have no fluid. If I start giving them nitro and Lasix, I can actually do really bad in these patients. So there's no way to tell that unless you have these fancy tools in the emergency department. For an example, I almost never give Lasix in my CHF patients, at least in the first hour. My whole resuscitation, and we'll talk about this, is done with nitro and BiPAP. And down the road, maybe an hour from then, if I've confirmed all this stuff, all right, now I'm giving Lasix, because my life-saving measures are in my nitro and my BiPAP. So my thoughts with Lasix: don't rock the boat, honestly. And again, I talked about this before. Matt showed me your possible new protocol for nitro and stuff like Lasix and ACE inhibitors. These are my personal feelings. And every person you talk to who deals with this has different feelings on it. My personal feeling in the pre-hospital phase, especially for short transport times, is don't rock the boat, because you may actually be treating something other than CHF. Morphine. Morphine is out. There's one slide on this. It causes respiratory depression. It kills people. There's studies that show the people who got morphine for heart attack or CHF died more than other people. So that's been out. Nitroglycerin, so we'll talk about that. It's a smooth muscle relaxant. So in low dose, it decreases, or it venodilates, so it decreases that preload. In high dose, it decreases your afterload, so arterial dilates. So it can kind of hit both things that we talked about before. So that's a great thing about nitroglycerin. Another good thing is you can give it multiple ways. Sublingual, you can do a nitro drip, you can do nitro paste. So a couple different ways you can give it, which is always nice to have medications you give multiple ways. So again, what it does, you put that nitro on board, you decrease the preload, you decrease your afterload, you decrease the amount of fluid that's coming in the heart and that's having to pump, and you're decreasing the pressure that the heart has to pump against. So you're really helping on every front. Dosing-wise, in general, a single sublingual is 400 micrograms, as well as a spray. It's good to remember what that means in IV dosing, because you guys will start going over IV dosing and learning what IV dosing is. And if you realize that one of those sprays or one nitro tab every 5 minutes is 80 micrograms per minute of nitro, if you give it every 5 minutes. The reason I bring that up when we try to teach the residents that is they start their nitro drips at 10, 20 like they're supposed to by the textbook, but you're actually severely underdosing the patient compared to just a single sublingual nitro. So it's good to know what those things actually do. The paste, there's been some studies to figure out exactly how much you're getting from paste. In general, that's how much you're getting right there. I don't love paste in the emergency department only because I don't actually know what the patient's getting. It depends on how much you put on, depends on their body habitus. Then someone goes by and wipes it off without a glove and they pass out on the floor. There's just reasons I don't love nitro paste. Until I've completely resuscitated the patient and stabilized them, then paste is okay. So our basic drip setting is 10 to 200 micrograms per minute. And you'll find this pretty much in any text, in any pharmaceutical thing. The problem with this, and we'll talk about that, is 10 and 20 and 30 is really kind of pissing in the wind. You're really not doing much. If just by giving a sublingual every 5 minutes, we're giving 80, now think of putting them on a drip and you're starting at 10. You'll see anytime you put them on a drip at 10 or 20, you are up titrating very fast because you're not going to actually see a clinical response. So you want to titrate up until you see about 20% systolic BP drop or symptom improvement, and slowly kind of start weaning them off. And the weaning is obviously something you won't do much in the pre-hospital phase. That's kind of our goal, is you slam them apart real fast in the beginning and then we kind of slowly get them off. Downside to nitro, main one is hypotension. So again, you're decreasing the amount of blood coming back to the heart, you're decreasing your arterial constriction, you're going to get hypotension, and obviously decrease preload. So in our right heart failure, right MI patients, we generally don't give nitro. Why is that?
Drops their preload.
Yeah, they're preload dependent patients. They're now infarcting the right ventricle. They need blood coming back to it. So now we're affecting that. So my take on it, hit them hard and fast, but be gentle. I'm a fan of high dose nitro. Sometimes we actually start at 400 micrograms. There are studies now that you actually give them an entire gram up front. So there's some studies with high dose nitro. I like to hit them hard and fast. A lot of people do 400 for the first 2 minutes and titrate down. Everyone in emergency medicine, every person has a different take on it. I like hitting them hard and fast, but I say be gentle because a lot of my residents, they come in, they know it's a CHF exacerbation, but the patient's blood pressure is 180, and now they want to do what they usually do for someone with blood pressure 260. I promise you within 2 minutes you'll be turning that nitro off because you'll bottom them out. So my take is over 200, I usually do a drip. Under 200, I do sublingual and paste. Because you'll see, you get a fast response. The next thing you know, the patient's pressure is 110. So you just got to be careful with it.
So once you get it below 200, you turn the drip?
I will start turning it off. I kind of titrate down a bit, make sure they still do okay, titrate down a bit, make sure they do okay. Yeah. Again, rule out right side MI, so using your right side EKG, because you can give nitro in these patients. With right side MI, you just need to be careful with it. Oxygen, there's no information put on there. It's good. And there's honestly probably not a case study to say it's good, but it's a very benign medication. You're not going to do harm with it, so go ahead and give it. And then positive pressure ventilation, CPAP and BiPAP. Again, we covered some of that in the asthma. And I'll cover why we do it here. Again, remembering just to be gentle with these patients and be nice when you're putting the asthma on. But one of the problems with CHF is this is your alveoli. So again, this is where all your gas exchange happens. One thing you get alveolar collapse. So you get a lot of fluid buildup in the tissues of the lungs that collapses your alveoli down. You also get a lot of alveolar fluid. So that fluid that should be somewhere else in the body is backing up into the alveoli. What CPAP and BiPAP does, it stents open those alveoli, so it gives a pressure gradient, stent them open, and it starts forcing fluids out of the alveoli. So that's why we do CPAP and BiPAP in our CHF patients. Also, CPAP actually physiologically decreases preload and decreases afterload. Due to different pressure gradients it causes in the intrathoracic area, it actually helps your preload and afterload and increases cardiac output. So for all these reasons, BiPAP can be a very good thing. There are some downsides to it because it's decreasing that preload. It can cause hypotension. Also, patient compliance. Again, it can be a scary thing to put on have a patient put on them. So those are two downsides. So the last thing, position. So we did our LMNO, now position. In general, this is bad. This is good. Questions? So here you're covering more of the lung parenchyma and surface area with fluid. Here you're not. So patient that comes in CHF, one of the first things we ask them is, how do you sleep at night? And a lot of them say, I sleep in a recliner. I sleep sitting up. You can actually gauge a number of pillows. I'm a 4-pillow sleeper because they cannot lay down because they stop breathing. All right, so we took our element P, we knocked one thing out, shift some things around, because the problem with element P, it wasn't in priority of importance. It was putting Lasix first, morphine, it was putting nitro and BiPAP in the back, and you kind of come up with a better mnemonic, POND. I like this one a little bit. I just was looking at an emergency medicine block the other day, and it presented POND, and I thought it was much more intuitive. It puts everything in the right order, and it knocks out what you don't need. So first off, P, positive pressure ventilation and position, oxygenation, nitro, and drive. And the D, they do use diuretics, but again, this is my personal one. If I'm in the back of the truck or a patient comes to the resus bay, this is what I'm doing. I'm not driving, but this is what I'm doing. And then think about other stuff down the line. So like I said, Matt would talk to me about the protocol earlier, which includes Lasix and ACE inhibitors. So I also want to touch on ACE inhibitors and why those are used and why they're good, why they're bad. So ACE inhibitors, anything that ends in a pril is an ACE inhibitor. And it's not so important that you understand how these work, but in general, your heart perfuses the kidney. It pumps blood to the kidney and perfuses it. When you have heart failure, you get decreased cardiac output, and your kidney senses, hey, I'm not getting the blood I should get, and it starts activating this enzyme called ACE, and ACE goes down this pathway right here, and essentially what it does, end result, it punches the heart in the gut, and it makes it vasoconstrict. It causes sodium absorption in the renals, and what it's trying to do is trying to increase your blood pressure, but again, it's kind of giving a punch to the heart when it's already failing. It's now making it pump against something a little harder, and it's now putting more fluid back into the system than it already had. So it's making that failed heart pump a little bit harder. So what ACE inhibitors do is they block that, and they decrease your afterload. So your kidney here, again, is trying to fight and make your body better, but what you're trying to do is actually block that so you're not pumping against that higher pressure. That's what ACE inhibitors do. They decrease the afterload to allow an easier environment for your heart to pump. So a good thing about them, it improves renal flow. So your Lasix that we used before is dependent on renal flow and needs to get to the kidneys to work. So what it does actually increases that flow, so allows that to work better, and decreases your afterload for your heart to pump against. The bad side is there's no great evidence to support it in the acute phase, but it takes focus away from other proven therapies. So there's a couple big emergency medicine podcasts out there, and they always have these experts on talking about CHF, and they probably talked to 6 or 8 of them, and every single one had a different take on if they use ACE inhibitors and when they use it. And that's just to say the evidence isn't great. Some people love it, some people don't. A lot of people say, well, if everything else is failing, I'll go ahead and put an ACE inhibitor on. Some people do it up front. So there's not a great consensus. My thought of it is it, again, kind of takes away the focus of everything else. When I'm faced with these patients, my mind is cluttered with a bunch of stuff, and one thing that always falls out is captopril or ACE inhibitor. And I've never given ACE inhibitor in the first 30 minutes of a CHF patient, only because I've never thought of it. That's the only reason. Like there's so much other stuff I'm thinking of, it just kind of falls out of my brain. Not to say it's not the right thing to do. So we'll wrap up with a case here. So 60-year-old male, end-stage renal disease, missed his hemodialysis, blood pressure is 230/110, shortness of breath, diaphoretic, crackles in the lung fields. And this is how I would approach this patient in the pre-hospital phase. Kind of a time on how I would approach it based on what the evidence I know. So you get to that patient, first 5 minutes, monitor vital signs. You want to make sure, obviously, they actually have a good blood pressure. Like I said, many of my residents, the patient hits the door and they're trying to get nitro hung or put sublingual nitro before getting a blood pressure. Often you get this patient, their blood pressure is 80/40. You're going to kill them with nitro. So just be careful. Take your time to make sure it actually is what you think of. Because bad heart failure, you can actually be hypotensive. They're commonly hypertensive, but a lot of times they're in cardiogenic shock and they're hypotensive. I get my BiPAP set up. I go ahead and put 2 to 3 nitroglycerin under the tongue. So I actually put them on BiPAP, I lift it up and I put those under the tongue. So now I'm getting about 80 to 150 micrograms a minute of my nitro, and that's going to kind of start their treatment. Because the nitro drip takes time. The nurse has to go get it, pharmacist has to get it, they have to spike it, set it up. So it takes time. In that 5 minutes, I'd like to get my EKG too if I can, because I might be dealing with a bad STEMI. STEMI and cardiogenic shock is bad. Those patients are really bad. That means they had a huge MI. So I want to make sure early on I know if it's a STEMI or not. Next 5 to 10 minutes or 15 minutes, I'm going to place them on the BiPAP, recheck my BP. So after that sublingual nitro, if I've dropped my BP below 200, I'm probably not going to put them on a drip. Okay, again, just because I know I've done it enough to know they're going to drop fast, I might just keep trying my sublinguals or do a drip at a very low rate. If they're still above 200, I'm probably going to do my usual drip. I'm going to start them off nice and high. And then here's my nitro drip. You can bolus 100 and 200 micrograms and infusion 100 micrograms a minute. That's kind of how I do it. Sometimes if they're really bad off, I'll start about 400 micrograms, but this is in general kind of what we're doing right now. Next 15-30 minutes, recheck BPs and symptoms. If systolic is still above 200, I increase my drip. You're really increasing about every 5 minutes or so, you're increasing that drip. If it drops below, I decrease my drip. And then 30-60 minutes, if I've confirmed hypervolemia and symptoms are continuing, that's when I do my Lasix, and that's when I consider ACE inhibitors. So at that point, everything's calmed down, the patient's stabilized, I've gotten my x-ray, they're full of fluid, I've done my ultrasound, I can see they're full of fluid. All right, now I'm going to go ahead and do my Lasix or my ACE inhibitor. And again, this is all just how I approach these patients. That's it. Nice and easy. Yeah.
So how do you, like, what's your personal preference on managing the hypotensive patient?
Hypotensive?
Hypotensive.
Poop my pants and call cardiology. I should turn my recorder off.